All right, case one. This is a 74-year-old woman who has a history of dermatomyositis for 20 years, and she began developing firm skin nodules about 4 years after her initial diagnosis. These nodules have become worsened over time. She's been developing more of them. They're widespread and have particularly began worsening after she stopped immunosuppressive therapy, and this was stopped because she developed a Mycobacterium avium intracellulare infection. She also has a history of recurrent infections during her course of dermatomyositis. Review of symptoms is she has significant widespread pain. She has occasional draining where there are skin ulcerations on the buttocks and knees. She has severe functional disability, but no constitutional symptoms, no fevers or chills. Physical exam, she has normal vital signs. She's very uncomfortable in clinic, but not in distress. And she has these widespread firm skin nodules, some of which are ulcerated. So here she is. You can see these nodules in various areas of her body, her buttocks, arms, shoulders, along tendons on the knees and their arms, and also on the buttocks. She occasionally develops these ulcerated lesions that have this discharge when they rupture. Here are her labs. She has an elevated sedimentation rate, a positive ANA, 1 to 640 with a speckled pattern. She also has a positive anti-chromatin antibody. Her ENA panel is negative. She had a myositis autoantibody panel done years ago, so without some of our newer autoantibodies that were tested, and her phosphorus, calcium, PTH levels are within normal limits. First question, what is the most likely diagnosis? Dermatomyositis paniculitis, osteoma cutis, metastatic carcinoma, calcinosis cutis, or disseminated MAI infection. Okay, most people think calcinosis cutis. The panel okay with this diagnosis? Okay, very good. So even without histology, based on the eyes in the audience and the history, this is calcinosis cutis. Here are some of her x-rays. This is her coccyx and around her lateral hip. Here's around her knee. You can even see these kind of linear calcifications around the tendon, shoulders, biceps, etc. So calcinosis cutis, as I'm sure all of you know, is the deposition of insoluble calcium salts not only in the skin but in the subcutaneous tissue. 5 different types have been described: idiopathic, iatrogenic, dystrophic, metastatic, and calciphylaxis, at least included in this relatively recent review article. In autoimmune diseases such as dermatomyositis, this is dystrophic calcification, which is thought to be the result of local tissue damage, and these patients typically will have normal serum calcium and phosphorus levels. In dermatomyositis, calcinosis is estimated to affect about 20% of adult patients and a much higher percentage of children, up to 70% of juvenile dermatomyositis patients. And the sites that are typically affected are similar to what we see in our patients: hip girdle, shoulders, knees, elbows, and muscle. When it involves the muscle and tendons, in the literature it has been referred to when it's widespread as Calcinosis Universalis. I think this patient probably qualifies for that diagnosis. And although we have no idea really why this occurs, it has been hypothesized that is the release of calcium from mitochondria and muscle cells that are damaged by the myopathy of dermatomyositis that may contribute. Next question. Which of the following has been demonstrated as a risk factor for calcinosis cutis in adult patients with dermatomyositis? Oral glucocorticoid use, anti-nuclear matrix protein autoantibodies, Gotrons papules, anti-TIF1 gamma autoantibodies, or presence of heliotrope rash. Okay, so about 31% think oral glucocorticoid use, and 31% think anti-NXP autoantibodies. So those are good guesses. It's actually anti-NXP autoantibodies. So we actually know a fair amount about risk factors in patients with juvenile dermatomyositis where calcinosis occurs much more often. There is a pretty broad literature describing risk factors in this population, which includes longer disease duration, persistent disease activity, where maybe these patients aren't being adequately controlled, and even internal organ involvement. But there are very few studies that have been done in adult patients. The study cited here, published in JAMA Dermatology in 2014 by David Fiorentino, Lorinda Chung, and others, was really one of the few studies to examine risk factors in adults. In this study, what they did was look at their fairly large prospective cohort of adults with dermatomyositis who are well phenotyped. In that cohort, they have 126 adult patients, and about 11% developed calcinosis along the lines of what has been published in the literature. And what they showed is that patients who had anti-NXP2 antibodies, as well as Rho52 antibodies, seem to have a higher risk of developing calcinosis, whereas, on the other hand, presence of TIF1 gamma autoantibodies seem to be protective, in their cohort anyway, for the development of calcinosis cutis. Now, when they looked at these patients and divided them based on their autoantibody profile, they found that a longer disease duration, as well as the presence of fingertip ulcerations, were associated with a significantly higher risk of calcinosis, regardless of their myositis autoantibody profile. Next question. Which of the following treatments for calcinosis cutis is based on high-quality evidence? Level 1, meaning either meta-analysis of randomized controlled trials or evidence from at least one randomized controlled trial. Diltiazem, colchicine, IVIG, bisphosphonates, or none of the above? Very good. It's none of the above. Unfortunately, there is very poor evidence that anything works well for calcinosis cutis. All of the answer choices I gave you are, in fact, level 4 evidence, which essentially is evidence from expert committees. These are often reported in the literature as either isolated case reports or maybe small case series. And there are, in fact, no evidence-based treatments that are available, despite the fact that many other treatments have been described in the literature in this population, again, but just in a single patient or in a handful of patients.
Tony?
Yes.
So okay, so the next is to get the big throwdown on what people would do?
Yeah.
All right, so then I would turn it over to our master blasters up here.
Okay, so with that said, this woman has widespread calcinosis cutis. It is significantly affecting her quality of life in a negative way. So what would you do? What would your next treatment be from this list? Diltiazem, colchicine, IVIG, bisphosphonates, or you wouldn't prescribe treatment because there is no evidence that anything works?
Yeah, I think it's very hard. I mean, it's just such a frustrating problem, and you really just want to do something, and I think that's how you end up with this long list. I think it's intriguing that this happened in the setting of stopping immunosuppressives, so you would wonder kind of, is there a way to keep her on chronic suppression for MAI? Is she hypogammaglobulinemic, which she could get like replacement with IVIG? And at this point, it's the cat's out of the bag, but would it be helpful to put her back on an immunosuppressive and just monitor, a little bit? But there isn't a right answer because no one's convinced that any of these things really work.
So in your practice, when you see these patients, is it really an individualized choice? I mean, clearly this patient has some comorbid diseases, this infection that may make you lean towards something like IVIG as opposed to another treatment, something that may help any active dermatomyositis as well as calcinosis cutis. Does anyone on the panel have a first option that they tend to go to in this situation?
Well, if you had just isolated lesions, I mean, people are doing intralesional sodium thiosulfate and maybe having some, it's extremely painful and somewhat time-consuming to do that because it's pretty acidic, so you have to really anesthetize the patient locally very aggressively. But we've seen some improvement with that, but, it's a long-term commitment. And for somebody like this, there's really no point in talking about that. And I don't know, Joe, at your institution, you guys have been doing some systemic administration.
So we do both. I completely agree with everything that's been said. We published that intralesional sodium thiosulfate thing recently, and it's meant for 1 or 2 lesions that are bothersome. I mean, this is an extreme. So this is obviously, I mean, for me, I just would underscore, I think I would treat the underlying disease, and the IVIG seems like the no-brainer here in terms of the infection risk and the sort of treating the underlying disease. That said, our group, and actually even more so at MGH, they have tried and continue to try systemic infusions of sodium thiosulfate that are very closely monitored. They do EKG monitoring but the problem I've found is that it tends to, if it's tolerated, it tends to come back, even if they have some early response.
Okay.
So this remains calcinosis remains a really particularly challenging problem.
Has anyone on the panel been? Go ahead, Dr. Chatterjee.
So I recognize this patient. I think we co-manage this patient. Patient has moved out of state now.
That's right.
So basically, the problem with this patient was her muscle disease was totally under control. So there was not a...
She really had no active dermatitis.
No active dermatomyositis.
Skin or muscle.
She did not have swallowing difficulties, no lung disease, no muscle disease.
I guess if you think the calcinosis is driven ultimately by the inflammatory disease, I would still sort of drive that way, I think. Personally,
I reached out to Dr. Chung, based on recent review that she wrote about what would you do in somebody with such rip-roaring calcinosis covering the whole, like universalis. And she suggested that the best options are surgical removal and intravenous immunoglobulin. So that would be feasible if you have small areas of calcinosis, but if it's covering the whole body, that would be a real challenge.
What was the deal and the status of the MAI?
So the MAI was actually recognized, and the patient required prolonged, antibiotic therapy.
Yes.
And she also had, that was incidentally discovered. It wasn't. She had underlying interstitial lung disease. So that was something that was recognized and addressed and hopefully adequately managed. The calcinosis is what was her main issue. And we have so many other patients with this problem.
Yeah. So it sounds like the audience had some mixed responses about what they would do. Okay, so this patient failed over about 6 years, bisphosphonates, both alendronate and IV pamidronate, colchicine, aluminum hydroxide, and amlodipine. So maybe I'll cut to the chase in the interest of time here. So in terms of the next treatment, we actually did try IV sodium thiosulfate. And we gave her the same dose that we give our patients with calciphylaxis, 25 grams 3 times weekly. She did this for 4 months, so she gave it a good try. And she stopped it mainly because she had a copay for every one of these infusions, so $150 out of pocket every month. But she was so desperate for any improvement that she was willing to pay that. However, after 4 months, she didn't think she was getting better clinically. We didn't think she was having any response, and so she stopped it. And as Dr. Chatterjee mentioned, about 8 months later, she moved to Houston, and so we've lost contact with her. But we are not the only ones who have tried IV sodium thiosulfate and have not seeing a result. There are several patients that have recently been described in British Journal of Dermatology. Joe and some of his colleagues, as well as other people that we in the Rheum Derm space know very well, reported 3 patients, similar dosing strategies, somewhere between 1 and 3 times a week. And none of these patients had a response to the calcinosis. On the other hand, as Joe mentioned, there is some literature about intralesional sodium thiosulfate. And Joe, I know you've done this obviously in at least this patient. And Vicki, it sounds like maybe you've used this strategy in some patients as well. So I'm just curious. Obviously, the patient we're describing has widespread disease, so this would be very challenging. But if there are lesions that are in particular causing significant pain or disability, have you found intralesional sodium thiosulfate to be effective?
We've done it only in a handful of cases. I mean, we published this one because we had particularly good success, and it was again in a setting where we could control the underlying disease. And I think that's part of the key, is that this was limited because this woman had lupus paniculitis that had been previously untreated. These lesions would calcify. So once we got her paniculitis under control, then I think we had some hope of trying this, and it happened to work out well. It was in areas that were amenable, and they really truly did melt away in these few areas. But if there's an ongoing process that's driving it, I'm not sure how effective it is ultimately. I think that's the problem with the STS is we've had people admitted for even high doses, and they sort of start to soften, maybe feel a little better, and then a couple months go by and it's all sort of back. And I think that was the challenge. In this particular woman, controlling the underlying disease helped get rid of them, and they haven't come back.
But you have seen some improvement in some patients with IV sodium thiosulfate.
Sure.
Okay. I always we didn't see any
but
response.
sustained.
Yeah, sustained. And I think the clinical trials really for calciphylaxis are ongoing, but
Right.
the calcium there.
But there, it's in the vessel.
It's in the vessels.
It's a different beast.
And IV, isn't gonna the dystrophic calcification in the soft tissues doesn't see that IV dose. So the intralesional may be a better strategy in the right patients. Any other comments from the audience about this case? Anyone with any experience with
Carmen
IV?
has a comment.
I don't have any better solutions how to treat this patient. We all have patients with this kind of presentation, and this type of condition is associated with a lot of depression.
Yeah.
So while we may not improve their baseline problem, I think it's important to consider the patient's reaction to their condition and consider maybe addressing the mood issues, the depression, the hopelessness, helplessness in this condition. So I think that can, to a certain degree, help our quality of life.
I think that's a great point,
And
Carmen.
Tony, not to drag it on too long, but I'm just wondering, from Lorinda or maybe Vicky knows this, in this particular case, is the NXP is it a marker bystander, or is there any thought that the anti-NXP is somehow pathogenic in the calcinosis? Because it's just in theory being, if you somehow pulled the NXP out, would it suddenly make this better?
Yeah, I think David did try to consider those things in that paper, but I can't remember the details about NXP.
Right, because that would be more of a Rituxan or something that would plasmapheresis. I mean,
Yeah.
something that would pull a pathogenic antibody out. But my guess is it's
Vicky?
probably bystander. But
I mean, it has effects on P53, and then that's also associated with malignancy. And so to the extent that, again, how it's driving calcinosis is really unclear to me. I mean, I guess another thing we haven't even looked at is something like rituximab, right?
Right.
Which, would be a little bit immunosuppressing on a patient who's already got more of a T cell probably based, process in terms of infections. But, it's kind of a desperate situation. And, rituximab might be something to think about, actually.
Great point. So this is a patient with extensive calcinosis in the setting of dermatomyositis, obviously failed multiple therapies, and this is an example of how challenging these patients can be to treat. And without question, calcinosis cutis in general, but extensive calcinosis cutis in the setting of dermato, as well as other autoimmune diseases we see, lupus, scleroderma, is a huge unmet need for this patient population.